Okay, I think we can start.
Well, good afternoon, everybody. Thank you for having connected to this most interesting webinar. The topic of the webinar is one of the most exciting ones, and it's about what to do when you have a patient with hemodynamical instability and a pending cardiac arrest, trauma patient. Which is the best choice to do in order to save the patient. The event is my guest. I'm very honored to have as a guest two most distinguished surgeon, trauma surgeon, that we discuss about the topic. Victor Reva is a member of the Kirov Military Medical Academy of St. Petersburg in Russia, and Dr. Demetriades is a friend of mine and a friend of us, and is a friend of all trauma surgeons. He's a professor at the Keck School of Medicine, Los Angeles, in University of Southern California at Los Angeles, and is the director of the Trauma Division and Emergency Surgery Division and Surgical Intensive Care Unit of University of Southern California at Los Angeles. And to resume the relevance of this surgeon, is one of the 1,000 top scientists in the world. And moreover, is a friend of mine. I'm very glad to guest him in this webinar. Federico, will you add a few words before the presentation, Dr. Demetriades?
Just a few words, we already discussed the rules. We will have 15 minutes for each in order to have the speech, and then at the end, all the people connected may have question and answer and chat in order to discuss with our top surgeon all the issue discussed, and to pose questions and to discuss the topic. So it's free to everybody, and everybody is invited and is welcome to participate. So let's start with discussion with the speeches, and then we discuss at the end. Okay.
Okay, and again, good morning to all. Good morning, Massimo, and good morning, Federico, and good morning, Victor, and all my good and loyal friends. It's 6 o'clock in the morning in Los Angeles, and I'm joining you from the hospital because I've been on call in the last 24 hours. And today we are going to have a very interesting discussion about the role of resuscitative thoracotomy or REBOA in the very sick trauma patient who is about to have a cardiac arrest. What is the right way to go? This huge invasive procedure, doing cross-clamping of the aorta, or maybe do this minimally invasive, beautifully looking REBOA catheter. This is a clinical scenario. We have a trauma to the torso, which is a non-compressible hemorrhage. You cannot compress it, you cannot stop the hemorrhage. And this trauma can be a gunshot injury to the chest or the abdomen. It can be a pelvic fracture with a lot of bleeding. It can be a big hemothorax bleeding in the chest. It can be an injury to the liver. It can be anything. The problem with the non-compressible torso hemorrhage is huge. In the military, there is a report that truncal hemorrhage is responsible for 67% of potentially preventable deaths. 67%, so it's a big thing. In civilian trauma, hemorrhage in the torso and hypotension has a terrible mortality, 45% mortality. So it is a big issue, and that's an excellent topic Federico and Massimo chose to discuss. Now let's come to the REBOA. as you know, is the hottest trauma device in the last few years. There are lots and lots of REBOA courses nationally. I've been having one at my center for many years. The American College of Surgeons introduced the best course to teach people how to do REBOA. Now there are numerous protocols and guidelines about the indications and technique of the REBOA placement. And more recently, there's a tiny REBOA, size 4, down from the size 14, size 7. Now we have a size 4, which make things much easier. The question is, in the year 2021, is REBOA effective? Is it really ready for routine clinical use? Experimental work has shown that REBOA improves short-term hemodynamics. In the next few minutes after you inflate the balloon, then blood pressure goes up. There is also good experimental work that REBOA improves the short-term survival. But the big question is, what is the effect of the long-term outcome? This is a patient here of ours with a REBOA place. You can see when the REBOA is inflated, it's high. Now deflating, the blood pressure keeps going down and down and down, down to 75. Now we are inflating the REBOA, and you can see the blood pressure goes up. So it really looks very good. But is this temporary increase of the blood pressure from 75 to 110 thing a good thing or not? We are not sure. There are many concerns. One concern is that by applying the REBOA catheter, you induce distal ischemia, ischemia to the bowel, to the liver, to the kidneys. There is big concern that now we make the acidosis worse, hyperkalemia and organ dysfunction potentially worse. Now, what is the clinical evidence supportive REBOA? There is no class or 2 evidence that REBOA improves outcomes. And number 2, some large studies, very large studies, suggest that the REBOA will result in worse outcomes. This is a study from Japan, the National Trauma Data Bank. They matched 452 patients with REBOA with similar 1,456 controls. And the result was that REBOA treatment was associated with a higher mortality when compared to similar patients who did not receive REBOA. That's of concern. There is another study, again from Japan. This time they got 625 patients with REBOA, matched with 625 patients without REBOA. All of them had torso trauma, injury to the chest or abdomen. All of them needed an operation or an angio evaluation. And this is the in-hospital mortality. 61.8% with REBOA, 45% with no REBOA, statistically significant. So let me tell you my own thoughts, anecdotal thoughts. What is the strongest indication for REBOA? In a question mark. Perhaps, we are not sure yet, perhaps in blunt trauma, carefully selected patients with extremely severe shock due to bleeding in a pelvic fracture like this one, or severe liver injury. And again, this is questionable, we are not sure. In penetrating trauma, maybe, again, I am not sure, severe bleeding in the abdomen after excluded injury to the aorta or the iliac artery. The reason for that you have seen 2 cases where there was a penetrating injury to the iliac artery. The catheter was placed through the femoral artery and came out through the perforation in the iliac artery. And you saw another case with an injury to the abdominal aorta when again the catheter came out of the perforation of the aorta. Now, what are the absolute contraindications for a REBOA? Number 1, in my mind, patients in cardiac arrest or imminent cardiac arrest. In my mind, it's an absolute contraindication for REBOA. It's a strong indication for resuscitative thoracotomy. I wouldn't even think remotely from 1 mile away to place a REBOA on this patient. A second possible absolute contraindication, it's bleeding in the chest. This is a cardiac tamponade patient. You do not want to insert a REBOA in a patient with a cardiac tamponade. And thirdly, if there is an injury or suspicion of injury to the thoracic aorta, it might cause a rupture. So again, to summarize, REBOA, in my mind, should be considered rarely in highly selected patients. In blunt trauma, in severe shock, bleeding in the abdomen or pelvis, very rare occasions. And I want to say it again. At my center, we teach all our fellows and chief residents how to insert a REBOA. We have many courses. We provide the courses to everybody. We apply REBOA no more than maybe 3 times a year. And again, the results are very questionable. All right, in penetrating trauma, again, extremely rarely, preoperatively. However, I see a good use. Now you are in the abdomen and there is a big hematoma in the retroperitoneum, zone 1, very high. And you want to gain control of the bleeding before entering this hematoma. I think it's a nice indication. I would use this without any hesitation. So, to summarize, in cardiac arrest, I would never consider it, I would not consider REBOA in imminent or cardiac arrest. If there is a clinical or radiological suspicion of thoracic aortic injury, and if there is any suspicion of intrathoracic bleeding. There is a lot of work out there comparing REBOA versus open aortic cross-clamping. In my mind, these studies should have been published. It shouldn't be any comparison between REBOA and aortic cross-clamping through a left thoracotomy. And the reason for that, they are very different indications. They are complementary procedures. In some cases, you might have to use the REBOA, like the intraoperative control of a hemorrhage. And in other cases, in the vast majority of cases, it's an emergency room thoracotomy. So these studies shouldn't have been there. So absolutely no consideration for REBOA in these cases with imminent or proper cardiac arrest. You cannot really do cardiac massage on a patient with a REBOA. You cannot really do the proper cardiac internal defibrillation on a patient with imminent or full cardiac arrest with REBOA. So these are my key points. And again, thank you very much. And I'm looking forward to hear my good and loyal friend, Victor. Thank you.
Thank you very much, Professor Demetriades. Very nice and absolutely precise indication for what yes and what not. Thank you very much, because it's very didactical, but very slightly precisely adherent to the clinical necessities of all people that may have to decide which maneuver, which device use and when. So let's hear about the remnant part of the topic from Victor.
Forza! È caduto da una gru! Forza! Sta perso tanto sangue! Poi... Infermiere, portatelo dentro, forza! Sorella, chiamate il professor Bellino. Va bene.
Questa l'emorragia si è fermata. Non solo quello. Morto, lo vedi. Portatelo via. Andiamo, ci sono gli altri pazienti. Aspettate, aspettate.
Non scappa.
Ok, la smetta immediatamente. Ma che sta facendo? Sto cercando di stimolare il muscolo cardiaco. Ma così sfonda la cassa toracica. Ma chi gliel'ha insegnato queste cose? Qualche stregone? Giuseppe, ti ho detto di smetterla. Questo respira. Bravo. Ne ho conosciuti di medici come voi. Dottorini animati dal sacro fuoco, convinti di saperne più degli altri. Scusate, professore, non intendevo mancarvi di rispetto. Solo che il paziente non supererà la nottata. Questo è.
Dear colleagues and friends, I decided to start my talk with this excerpt from the fantastic movie from 2007 about a saint Italian doctor who treated the poor in Naples in Italy. And this a little bit is associated with my today talk about critically unstable patients and pending cardiac arrest. I'm trying to focus on cardiac arrest and pending cardiac arrest and use of REBOA. And that patient fortunately survived. And 100 years later, we treated quite the same patient who bled to death, who was fallen from height on the fence with a huge injury to the perineum and pelvis and high upper thigh. Witnessed arrest upon admission, and we used Lucas device as an external compression and zone 1 REBOA, as you can see here, with successful return of spontaneous circulation in zone 1. And obviously the hemorrhage was in the pelvis and not above, no free fluid in the abdomen, and the huge wound in the perineum and thigh was packed, but bleeding was continuing. And we switched from zone 1 to zone 3 because of no free fluid in the abdomen, and additionally embolized the source of bleeding in the pelvis and upper thigh with the glue, as you can see here, with both internal iliac arteries embolized. This patient was under-resuscitated with fluid and unfortunately died within 12 or 16 hours. And we tried to define why this patient died, and many other patients who experienced REBOA in our reality, in our trauma center. And we compared our group, 24 cases in our clinic, with all the rest of the patients who are represented in ABO trauma registry. As you can see here, and mostly the differences were associated with resuscitation strategy with crystalloids and colloids. We are using more crystalloids and less blood and fresh frozen plasma and less platelets according to other clinics. And that may be an issue and not REBOA itself. However, when we performed a matched pair analysis, there was no difference in early and discharge survival. As you can see here, when our survival was only 17% and 33% in the rest of the ABO trauma registry. This data from all these clinics, 16 centers represented in ABO trauma registry, are presented here with the paper published in Shock by David McGreevy. And this is focused exactly on impending cardiac arrest. And impending cardiac arrest means here is blood pressure of 40 or less upon admission. And you can see that most of the patients who died has had blunt traumas compared to penetrating traumas. And if the patient suffered or developed a cardiac arrest and underwent CPR upon admission, the patient had significantly higher chance to die. In this particular paper, they demonstrated that REBOA in impended cardiac arrest is feasible. It leads and it results in a significant increase of blood pressure from about 10-20 to 60-70, which allows performing some kind of procedure, diagnostic treatment, and additional resuscitation using blood or fresh frozen plasma. And they found that 36% of patients with impending cardiac arrest survived if REBOA placement was successful. In our successful case that was also presented in this particular registry, it was in military, and despite in limited resources, the mechanism of injury is represented here. The patient was arrived severely hypertensive with undetectable blood pressure and severely recognized pulse on the carotid arteries with their decreased Glasgow coma scale, severe pelvic fracture, and not severe chest injury, and FAST was positive upon admission. The first X-rays were performed with the balloon in place, as you can see here, via the right femoral artery cannulation. Sheath was placed in the right femoral artery. The balloon is in place in zone 1, and the blood pressure was increased from 0 to 110, as you can see on this slide. What allowed us to perform laparotomy, which was just exploration laparotomy, because of a hematoma was expanded from the zone 3 from pelvis. The preperitoneal packing was performed, and the dwell time of the balloon was only 16 minutes. And during this 16-20 minutes, we managed to transfuse 5 to 6 packs of red blood cells and 3 to 4 packs of fresh frozen plasma. So the patient was adequately resuscitated and fortunately survived to discharge. And later, I saw him 2 years after this event. And we realized that there are different clinical conditions, and we are talking about critically unstable patients, and they may be very unstable, experiencing impending cardiac arrest or imminent cardiac arrest or cardiac arrest. And when I tried to extrapolate how we made a decision about REBOA or resuscitative thoracotomy, I used as a sample, I used membrane action potentials and all or nothing law from physiology. And when a patient is stable or unstable, not critically unstable, it is easier for us to make a decision about REBOA, because patient has some kind of pulse, some kind of pressure, and when cardiac arrest, true cardiac arrest occurs, the decision to thoracotomy is made more easily. And this is the line between impended cardiac arrest and true cardiac arrest, because of when we have a true cardiac arrest, then balloon in aorta actually gives nothing because there is no flow. Some papers published from the Baltimore group, AST aorta study group, found that REBOA can confer a survival benefit over resuscitative thoracotomy, especially in patients not requiring CPR. So for impending cardiac arrest, when the patient is not completely arrested, REBOA has a benefit. And from this particular paper, we have a big figure demonstrating that when the patient is experiencing CPR pre-hospitally or upon admission, there is no actually benefit for survival between these groups, resuscitative thoracotomy or REBOA. And if the patient is hypertensive, there is a survival benefit, which is statistically significant. And if a patient underwent resuscitative thoracotomy and was severely hypertensive, the survival was 0 upon discharge compared to 44% for REBOA. And we realized that despite many authors declare 3 to 7, even to 10% of survival in blunt trauma and emergency department thoracotomy, we realized that this number tends to 0 in many cases. What we have, if we can compare resuscitative thoracotomy and REBOA in these groups of blunt polytraumatized patients, and what we have performing resuscitative thoracotomy, Dr. D described all this open cardiac massage. This is the advantage of resuscitative thoracotomy, cross-clamping of the aorta and thoracic bleeding control. Okay, we can perform open cardiac massage simultaneously with REBOA, but in most cases it's not needed. We can apply closed cardiac massage with a device like Lucas, and we don't waste time for no flow time while performing a thoracotomy. The Lucas device is working and maintaining at least some flow for brain and heart perfusion. During this closed cardiac massage, we perform REBOA, which can be controlled. We can partially deflate it because of cross clamp to the aorta. It's difficult to declamp partially. We typically we just declamp the aorta maybe in some stages, but we cannot control the level of aortic occlusion. And of course, while we perform in REBOA, we have an arterial line which can be used for angiography, for gases analysis, for endovascular procedures if required, as for example in the case that has been demonstrated. And of course, it is preferable for abdominal pelvic injuries with bleeding because of in chest, in cardiac rupture, in thoracic aortic rupture, it is REBOA is contraindicated. If comparing open cardiac massage and closed cardiac massage, we found in the literature that there is no benefit from open cardiac massage compared to closed cardiac massage, published from Baltimore group. And when we decide whether we use REBOA or not, we need to answer to most of these questions. What scenario, what circumstances, what we have, are we ready, what are the mechanism of injury, level of training and equipment. And for example, for this particular patient, is it easily performed resuscitative thoracotomy or groin access for REBOA? And for example, for these cases, with when the patients are exsanguinated to death and there is obvious source of bleeding, is it the patient who is a candidate for resuscitative thoracotomy if he's arrested upon admission? Or this particular patient with the age of 75 with bilateral occlusion of both iliacs with failed attempts to both femoral arteries to perform the REBOA. And according to injury pattern, we prefer to use REBOA for these regions, especially for pelvic injuries and high lower extremity injuries, as was demonstrated. And we don't use now, maybe we will change our strategy in the future, because there are more and more papers appearing in literature about effective use of REBOA even in chest injuries. But in chest, for example, this particular lady fallen from 9th floor with a pelvic binder applied and REBOA catheter in zone 1, and there was no effect on hemodynamics. We performed simultaneously, we performed clamshell thoracotomy, as you can see here, with pericardiotomy and open cardiac massage, and the injury was the suprahepatic intrathoracic IVC segment with a blunt rupture, 2 centimeters long longitudinal rupture of the IVC, intrathoracic IVC, which was sutured. Unfortunately, this patient also died. Again, we can use REBOA as the variable control technique. alternate technique, and especially in IVC injuries and retrohepatic IVC, when we shoot and we need to occlude this IVC in a high level, even above the liver, and that significantly diminish the preload and can lead to cardiac arrest. And in this particular case, REBOA can help to support hemodynamics and compensate this decreased preload. It looks on angiography, you can see that the balloons can be used for both IVC and for aortic occlusion, and the difference is presented here is just animal studies and out of high-level evidence research. But we found that if there was no REBOA, then all the animals experienced cardiac arrest because of diminished preload. And REBOA just helps us to support hemodynamics and avoid this cardiac arrest. And this study was mentioned by Dr. D, and there was no, this paper demonstrated no difference between REBOA and aortic cross clamper with regard to mortality, as you can see here, and 28% mortality for REBOA and 16% for open resuscitative thoracotomy. This paper demonstrated that 40% of cases in US trauma centers, REBOA was used as a bridging stabilizing maneuver, comparing to 60% of open techniques. And what is important that time from admission to aortic occlusion for REBOA is about 6 minutes, and for resuscitative thoracotomy is about 7 minutes. Maybe in Los Angeles, this time is even lower, as I saw on the video. The video is about 1 to 2 minutes, but not in all trauma centers, I suspect. And independent traumatic cardiac arrest, REBOA may not work in cases mentioned here, that the patient is already dead, something ruptured above, like heart, left atrium appendage, or left atrium, or thoracic aorta is ruptured, or balloon ruptured, which can be easily identified upon inflation. And balloon is somewhere else, which happens, but very rarely. Anyway, regardless the reason, we can proceed with the resuscitative thoracotomy if something went wrong during REBOA. And one of the recent paper published in Shock about REBOA concluded with this final and very nice proposed algorithm for REBOA in traumatic cardiac arrest. Of course, we try to prevent true cardiac arrest using REBOA, just to push blood pressure a little bit up. And according to this strategy, you can see that emergency thoracotomy is okay only for thoracic injuries, and it's justified. And compared to abdominal and pelvic injuries, when we have the same time to aortic occlusion from open or endovascular techniques, why don't we try with femoral puncture and then put the balloon to zone 1, inflate and stabilize the patient to proceed with surgery, hybrid surgery, open surgery, or even endovascular surgery, as was demonstrated in many publications from our Japanese colleagues. So, drawing a conclusion, I would start with REBOA and impending traumatic cardiac arrest in these cases, in confirmed intra-abdominal or pelvic, severe abdominal pelvic injury and hemorrhage. When everything is set, we have a balloon catheter, we have a X-ray readily available, ultrasound, and we are ready to open surgery. We don't use REBOA for elderly patients because in 2 out of 3 cases we had severe calcified femoral arteries, and we don't use it anymore. And of course, no obvious thoracic trauma. If we suspect that there is severe thoracic trauma, and this is the reason, and this is the source and main main reason of patient instability, I would personally proceed with the clamshell or left side thoracotomy immediately. And of course, while performing REBOA, we don't forget about resuscitative thoracotomy. We can do it together, combining with two teams. One is performing femoral axis and another one is performing left-sided thoracotomy. Institutional protocols should be developed and followed strictly until high-grade recommendations appear, as was already focused by Dr. D. Thank you very much for your attention.
Thank you very much, Dr. Reva. Your presentation is absolutely complimentary, and for many parts, it's in line with the one from Demetriades, because at the end, many of your ideas are similar. But maybe one of the point that emerged clearly emerged from that the REBOA is, for some aspects, more complicated from the organizational point of view for the center who may start to use, because REBOA is something, a bridge from one point to another, and is to be used with a lot of attention, because it may bring a lot of complication. Yes, for sure, even the thoracotomy, but maybe REBOA is worse from the complication point of view if may be applied with wrong or not completely right indication. What do you think about this?
Go ahead, Victor.
Okay. I think this is the issue of training, actually, and all the complications. Many papers have been published on complications, and those papers embracing the period and spanning the period when bigger catheter were in use. Just a few years ago, you know that we used 12 to 14 French catheter. Of course, with big holes, with big problems and big complications. Now with the 6 French and even 4 French, you can just puncture the pedal artery, or I don't know, maybe we will have REBOA catheters that can be advanced to thoracic aorta via upper arm or from brachial artery. Maybe the level of complication, and I think that now the level of complications is decreasing because of the size of the catheter. And about the complicated circumstances, I can say that, of course, for resuscitative thoracotomy, you need just a scalpel. And here for REBOA, you need a bit more pieces. And if all is set and you know how to do, and you have a team that can help you, then there is actually no big difference.
Demetriades, would you like to?
Yes, first I want to say that Victor did an amazing job, a beautiful presentation, beautiful lecture. And I think, as you pointed out, in many parts we have an agreement. Just I want to give you the setup we have at USC in Los Angeles. As I mentioned, we train all our fellows on human cadavers how to insert a REBOA. And in fact, the trauma fellow on call carries a bag with him on his shoulder 24 hours a day. And in this bag, we have all needed for the REBOA. They can insert the REBOA within maybe 3 or 4 minutes, very quickly. However, we do more than 100 resuscitative thoracotomies a year. We do 3 or 4 REBOAs a year. Because I think the circumstances are quite different. Firstly, the evidence out there is terrible. It's terrible. I reviewed this paper from the Shock Center for the Journal of Trauma, and I recommended reject. This is a bad paper because they compare apples with oranges. Obviously, the patients who had the resuscitative thoracotomy were dead. On the other hand, those with the REBOA were alive. So they cannot make a comparison. I suggested to the editor, this is nonsense, rejected, but it was accepted because it was from the AA's team. I think a strong indication for REBOA, as Victor mentioned, and I agree with that, if you have bad perineal injuries and you cannot go to the operating room immediately, I think that's a good indication. For pelvic fractures, maybe Camila know, and we published quite a lot on that. Our approach at USC is to go in the operating room immediately and do bilateral internal iliac artery clipping. We open the hematoma, we look for any injuries to the major veins or the arteries, and then we clip both internal iliac arteries and we pack very tight. And again, especially in Los Angeles, different situation, the pre-hospital time, 7 minutes. 7 minutes it can be in hospital. So very quickly and immediately the operating room is above the emergency room. So the times are very quickly for hemorrhage control. We prefer to do it that way. But if on the other hand, you do not have the operative capabilities, the interventional radiology capabilities, and you are going to transfer the patient 1 hour by helicopter or car or whatever, if we want to insert the REBOA for this terrible pelvic fracture, I think it's a reasonable point. It's a reasonable option. So to summarize, I think it shouldn't be comparison between one or the other. They are complementary. In very rare cases, in my mind, REBOA has a place, but it's very limited. It's still experimental. It's not ready for routine clinical use. Don't feel guilty that your hospital does not use REBOA. Thank you.
May I raise a question to both the speakers? Federico?
Yes, for sure.
Yeah. Okay. Just an example of a trauma scenarios. You have a guy who is unstable after blunt trauma, but he does not need cardiopulmonary resuscitation. You are quite sure that the source of bleeding is inside the belly. What would you do? The patient is stable. Would you perform REBOA? Would you perform resuscitative thoracotomy? Would go directly up front laparotomy?
So, Massimo, the injury is pelvic fracture?
No, you have an instability with blood in the belly, not necessarily pelvic fracture.
Yes, yeah. Victor, would you like to go first?
Yes, I can.
Remember, the patient does not need cardiopulmonary resuscitation. He's unstable, pressure very low, but you need to do something to stop bleeding.
Yes, we will start according to how much low this blood pressure. If the pressure is 90 to 80, I would probably this patient will receive a sheath in the femoral artery, 5 to 6 French sheath for invasive blood pressure monitoring, and the balloon catheter is already somewhere around the patient. And if patient is with 80, 70, and we see that the patient is progressively deteriorating, we will proceed with the advancing catheter into the thoracic aorta, and the laparotomy pack is already open, and we start laparotomy. It can be done simultaneously. And if the free fluid in the abdomen is confirmed, we do it simultaneously. One is puncturing the femoral artery to put the balloon in. It can be deflated if the patient is quite okay, not less than 70 maybe. The balloon is in. It's this a kind of support for us. And if, for example, at the initiation of narcosis, the patient is arrested or blood pressure dropped immediately, we can inflate to support hemodynamics. So I would start with REBOA. I don't start with the patient with detectable blood pressure with the resuscitative thoracotomy. Maybe the reason for for resuscitative thoracotomy would be if it's penetrating trauma. But for blunt trauma, I would start with REBOA and simultaneous laparotomy in this particular case.
Demetrios?
Yeah, I think it depends very much on the circumstances in your hospital or your capabilities. At USC, very quickly, within minutes, the patient can be in the operating room. And very often, in selected cases, we'll use the hybrid operating room, where simultaneously we can do the laparotomy and the angio intervention team can do angioembolization as needed. But if in your hospital, you do not have this setup to go to the operating room very quickly, the surgeon is not in hospital or something else, I think it makes reasonable sense to try to insert a REBOA. But at my place, the only place is the operating room.
Okay. Thank you.
There is a question from Dr. Galatiotto. Is it necessary and how long the training must be to perform an emergency thoracotomy?
Just say it again, Federico.
There
The
is a
sound was
question
not so good.
asking for the necessity of a training to perform an emergency thoracotomy and how long the training should be.
The draining, what do you mean draining?
No, training.
Oh, training. Oh,
Sorry.
It's the emergency room thoracotomy. It's embarrassingly easy. We teach first all our residents on our cadaver lab. It takes no more than maybe 2-3 minutes to be in the chest. It's embarrassingly easy. We do more than 100 a year, and our second-year residents, are capable of doing this. And Camila saw a lot when she was with us in Los Angeles. Very easy.
Okay. Another
How many did
question.
you save, Camila? How many patients did you save while you were in Los Angeles?
Okay, that's another interesting, Victor. Victor mentioned that the survival varies a lot from very low to very high. It depends very much on the indications for your thoracotomy.
Blunt. We are talking about blunt.
Blunt. Okay. Again, it depends very much on your indications for thoracotomy. If you do thoracotomy for chest trauma or blunt trauma, probably in our hands about 3%. But we do thoracotomies, emergency room thoracotomies for everybody. Everybody. The patient was hit by a car and he had a cardiac arrest in the ambulance. He comes to the USC, he's going to have a thoracotomy.
A democratic
And the reason
procedure.
for that, even though the survival probability is very low, every now and then we get organ donation. This patient survives with brain damage and he becomes an organ donor. And we publish on that the only outcome should not be the survival of the patient. The possibility, the chance of organ donation should be part of the outcome. If I did this thoracotomy and the patient became an organ donor, it saved 5 people, different people, that's a great outcome.
This is a very important issue. It should be considered among the patients from trauma because many of them are young and many of them have some organs that may be donated. So we should consider even this topic in deciding what and which technique to use. There is a question from the Far East for Victor regarding if you go in chat button, you may read, but there is about, the question is about the selection to use REBOA for the patient in under 65 years old. Why?
The reason is the high probability of atherosclerotic lesion in these patients. We had a case with, according to our protocol, REBOA was required, but we failed to puncture first femoral artery and then the second. And a bit later, when we performed angiography, we found that both iliofemoral arterial segments were occluded. Another patient with the age 82 or 83, something like that. We put the balloon in with a long sheath and damaged their. So we provoked a dissection in iliac. It was kinked in iliac artery, and there was a dissection, and then required thrombectomy from this segment. So it was a complication. We fixed that, but for elderly people, we don't use it anymore because of these probable problems.
There is a comment from Ireland, Professor Balfe, who says that emergency thoracotomy in very extremely unstable patients should be the first choice. So it's in line with Professor Demetriades. I think that one point to stress before concluding is that, as told by both our speakers, is that REBOA and thoracotomy are not mutually exclusive, but they are complementary. So people must learn to perform both technique, maintaining into the head and into the protocols the possibility to perform one or the other according to the facilities of the center. I would like to launch a provocative question to Demetrios and even to Victor. Some very few cases in the year, so the possibility to perform or the needing to perform an associated intervention to an hemorrhage in thorax or in abdomen, and also inside the head. But once we go to the operating room with an unstable patient, the most part of the time, we are not able to investigate the eventual lesion inside the head because we don't perform the CT scan because we have an hemodynamically unstable patient. So what do you think regarding the eventual use of REBOA in order to perform an ongoing CT scan to investigate only the head before rushing to the emergency to the operating room, and then perform the associated intervention to the abdomen and eventually thorax and the head?
That is a very interesting question, Federico, and a very practical question. In fact, very recently, we did a huge study. When you have a combined head trauma and abdominal trauma, what do you do first? And you suggest maybe put the REBOA, stabilize the patient, do a CT scan of the head, and then go to the operating room. In that study, we found that in hemodynamically unstable patients with combined head and abdominal trauma, the chances that this patient will need an operation in the head are less than 3%, less than 3%. So, in fact, in the study, in the conclusion, we suggested that the patient goes straight to the operating room, stop the bleeding in the abdomen or the chest, and once you do that, then you can go to the head CT scan. The chances that this patient will need both a craniectomy for drainage of an intracranial hematoma plus a laparotomy is less than 1% of these patients. The study was, I think, either was published or will be published very soon in the Journal of Trauma.
This is one of them. Do you have any comment, Victor?
I totally agree. One time I had a case with the patient arrested or nearly arrested because of severe head trauma. So it was admitted to our center, and we went immediately with the REBOA, and the only injury was the intracranial. But the REBOA was a kind of stabilizer, so we just use it to increase the blood pressure until a certain level. We know that for severe TBI, we need to maintain blood pressure above 100. And the REBOA, we just can equilibrate with the balloon. We just push it a little bit in and it's a kind of mechanical stabilizer, and we can use this device to take the patient into the CT for diagnosis. Otherwise, we just cannot do anything. The patient is in the OR and it is unstable, and we need to use simple diagnostic tests. Using REBOA, we just maintain appropriate blood pressure to let the patient go to the CT for diagnosis.
There is another question from South Africa. Pradeep Navzaria is asking if one of you or you both have any experience with the use of REBOA and LODOX technology, because in his hospital, he has not the possibility to access to the hybrid operating room. So what do you know, or do you think, or if you know about this topic?
So I had a chance to visit the Prof. Navzaria clinic in South Africa and saw how they used this LODOX diagnostic system, which allows to perform the whole body X-ray within 15 seconds. And I assume that most of these LODOX systems, they are in South Africa, and some are out of their country. I had no experience, but along with the second question from Prof. Navzaria, we also don't have a hybrid OR. We use for this patient, we use just operating theater, and to confirm the position of the balloon. By the way, we use simple cassettes for X-ray, and no fluoroscopy immediately available. So I have no experience with LODOX, but also with a hybrid OR.
Right. LODOX is a South African device, and I was very impressed with that. When we built the new hospital in Los Angeles, I made sure that we installed a LODOX system. And we use it quite a lot at the very beginning. We haven't used it, it's laying there empty in a room for the last couple of years because of the new radiology technology. We can do the same thing in the emergency room without moving the patient to the LODOX. We do have an hybrid operating room, and I think it's really very useful for this kind of injuries combined, pelvic fractures, bad pelvic fractures, liver injuries with packing. Sometimes there is an intra-abdominal injury with a thoracic aortic tear. So on the same table, we'll do a splenectomy, and at the same time, the vascular surgeon or the interventional radiologist places a stent in the thoracic aorta. So it's really very useful to have.
One last question from the Far East, again, regarding the tips in placing REBOA. If you have not enough time to perform a film, an X-ray, to confirm the positioning of the balloon, how do you manage?
Yeah, Victor, you are the supporter of the REBOA. What do you do?
Yeah. So we try to minimize this time from balloon inflation to X-ray, and we do it by putting the cassette before the patient is admitted. But when we have a call that the patient is going to be in our hospital soon, we put, and this patient is severely unstable, we put these cassettes on the table, and once we inflate it, we should confirm it within as soon as possible. I would say, not immediately, because clinical scenario can lead the process. If the patient is critically unstable, we can do it a little bit later, but we confirm at least once where the balloon is and how completely it occludes the aorta.
Yeah, sometimes you do X-rays. In most of the cases, we do not. We use external landmarks. For example, for zone 1, we use the middle between the suprasternal notch and the xiphoid. In the middle, zone 1 is very good. For zone 3, not very reliable. We did a lot of cadaver studies. which show that zone 3 external landmarks are not very reliable. We try to use the middle between the xiphoid process and the pubic symphysis, but again, it's not so good. So ideally, I agree with Victor, if you get the chance, the opportunity, get an X-ray. I just have to tell you, a couple of years ago, I was a visiting professor at the Shock Center. And John DuBois, who wrote all these papers on REBOA, he used to be one of my fellows. So he presented an interesting case with penetrating trauma to the abdomen, and they placed a REBOA. And the REBOA, they didn't take an X-ray. And the patient had an injury to the common iliac artery. And the catheter came out through the injury to the iliac artery. And we had the same, I saw another case at another center, exactly the same scenario. So it's good if you have an X-ray taken as soon as possible, as soon as time allows.
Another question from Dr. Sartoni, asking regarding unstable patient with hemoperitoneum due to major liver trauma, but without the need of cardiac resuscitation. May the aortic clamping at the hiatus plays a role instead of REBOA or resuscitative thoracotomy?
Right, so you are in the abdomen, you do an operation, and the patient is bleeding a lot from the liver, and the question is, can you cross-clamp the aorta below the diaphragm? The answer is yes, absolutely yes. You do not need a thoracotomy on that. And the secret is, and again, we train our fellows and our residents in the cadavers on that. You pull the left lobe of the liver down and the stomach down, and then you divide the esophageal foramen, the aortic foramen at 3 o'clock. 3 o'clock. At 3 o'clock, there are no branches of the artery, so there is no bleeding. And then you cross-clamp the aorta below the diaphragm. This is our recommendation, and this is what I would do. On the other hand, if you have a big hematoma, retroperitoneal hematoma, very high, supramesocolic, you cannot find the aorta below the diaphragm. In this case, you might have to do a thoracotomy, a left thoracotomy.
So I can add my 2 cents to this comment. And we had the case with a severe blunt abdominal trauma with grade 5 splenic and grade 5 left kidney injury shattered. And we started with the balloon in place, opened the abdomen. There was no ongoing bleeding. We just put the spleen and take it out to the basket, and no ongoing bleeding because the balloon was occluding the aorta. And then when we fixed it, we found that there is an additional source of bleeding behind the liver, and it was not easily seen. And when we tried to mobilize, we found that it was suspected as a retrohepatic liver injury, and we put another balloon, punctured the femoral vein in parallel to the femoral artery, and inserted another balloon to the level of hepatic veins, and we mobilized the liver and sutured en masse the left hepatic vein. It was injured immediately at their confluence with the IVC. So this is a maneuver you can use. This balloon is just temporary technique to stabilize not only patient but the situation. Just comment to this question about severe liver injuries.
Yeah, Victor, I think that's a good idea. In fact, we've been trying this on cadavers. We have human cadavers with perfusion, cardiac perfusion and ventilation. And we try this for retrohepatic vena cava injuries. It's a nice concept. We haven't used it yet in a clinical scenario, but I agree. It sounds a very good idea.
I just have a question for both of you. So first of all, thank you both because the presentations were really useful, and especially in keeping Can I speak? Okay. Especially in keeping in mind which patients may benefit from the REBOA use. But one question, when you have you already perform a trauma laparotomy and you find yourself in severe difficulty in controlling a bleeding, a pelvic bleeding, and this patient has a pelvic fracture, would you consider, especially you, Dr. D, using the REBOA, or would you go directly with bilateral clipping of the internal iliac arteries?
Yeah, you know, at USC, we introduced the technique, and we've been using this technique for many, many years.
Yeah, I remember.
We'll go in and we'll explore all pelvic hematomas. The reason for that, and we publish on that, more than 12% of patients with bad pelvic fractures have a major injury to one of the iliac arteries or the iliac veins. And you really need to go in and repair, ligate this transected common iliac vein, external iliac vein or artery. So we'll explore. Once we make sure that there is no major vascular injury, we put temporary clips of both internal iliac arteries, and then we pack very tight. This is our approach.
Yeah.
I can comment. I knew from this LA technique from Camilla when I was in Pisa, and she said about this approach. I can say that now we investigate another thing, and when we realize that the main source of bleeding is in pelvis, we just puncture the both iliacs, internal iliacs, with the venflon, with the catheter, and we combine. It's a kind of hybrid technique when we open the origin of the iliac artery and push into the both iliacs gel foam. So we combine the techniques endovascular. When people try to diminish pelvic bleeding, they do radial access or femoral access to embolize with these all catheters going through the vessels. You are already in the abdomen. You can puncture the origin of the internal iliac from both sides and fill the both iliacs with gel foam. It resorbs in 1 week or 10 days. So it's a kind of damage control maneuver. You don't need to ligate it permanently. You just temporarily push the gel foam. It's a kind of hybrid procedure with semi endovascular procedure.
Yeah, that's an interesting thought, Victor. Initially, at the early stages, you used to ligate permanently the internal iliac arteries. Now we put clips, temporary clips. And the next day, when you go back to remove the packs, we remove the clips.
If you don't need to go back to the abdomen, you just push this sterile gel foam into the iliac, and that's all.
Okay.
Yeah.
Thank you.
I think that we saw very interesting speeches and a different point of view, very different. And maybe the different point of view are influenced by the formation of the different of the two guys, because Demetriades is a general and trauma surgeon, and Victor is a general and vascular surgeon. So different formation and different approaches. And maybe one of the main suggestions we can give even to the young resident who will eventually decide to face the trauma surgery as the job of their life, the necessity to study a lot and to maybe even hybridate their knowledges with similar professional pathways in order to get idea, to maybe decline in different solution in the different situation, because sometimes during trauma and emergency surgery we have to apply the traditional techniques but differently, and we have to adapt the techniques and the solution to the patient. So maybe we can more also add it to the old teachings these two great surgeons gave us. We may even add the necessity and the teaching to try to learn and to hybridate our formation with the formation of other guys who maybe do quite similar but not completely equal jobs in order to improve our outcomes in our patient and maybe to reduce the impact on our patient. So I thank you both very much. I would like to remember to all the people who participated, they will receive the certification of participants. And then in the mail, they will have even the link to the YouTube channel into which all the appointment, the data, all the speeches of our meetings are uploaded. So they can even listen and see again the presentations, or to share with other people in order to diffuse the teachings. Thank you very much to everybody.
And again, I want to congratulate Federico and Massimo and the team there for putting together this amazing workshop. I think it's very educational, very useful to people from all over the world. That was an excellent idea, and congratulations. Thank you.
Grazie Demetrio, grazie Victor.
Take care. Bye.
Grazie davvero.
Bye.
A presto.
Bye to everybody.
Thank you everybody. Goodbye.